This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Which PAP is Right for You?
ResMed changes lives by developing, manufacturing, and distributing medical equipment for treating, diagnosing, and managing sleep-disordered breathing and other respiratory disorders. ResMed develops innovative products to improve the health and quality of life of those who suffer from these conditions. ResMed has solutions to meet the needs of all of your patients, starting with our range of AirSense CPAP and AirCurve bi-level devices, all featuring built-in heated humidification and wireless connectivity, giving you daily access to therapy data via AirView, ResMed's cloud-based patient management system. To high-end ventilation solutions, such as Astral Life Support Ventilator, designed to meet the needs of your more dependent patients. Astral's discreet and lightweight design allows patients to go beyond the confines of the home environment while delivering real peace of mind to them, their clinicians, and care providers. Designed for both invasive and non-invasive applications, Astral has easy setup and simple servicing, making ventilation support for critical patients straightforward and efficient. Reach out to ResMed today to learn more about our wide range of sleep and respiratory solutions for all your patient needs.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to define obstructive, central, mixed, and complex sleep apnea, identify which type of PAP device is appropriate for each type of apnea, identify types of mask interfaces available, and define common complaints regarding PAP therapy and ways to correct issues. I am pleased to welcome Ms. Jessica Schweller. Jessica is a registered respiratory therapist and sleep nurse practitioner at the Ohio State University Lung and Sleep Center in Columbus, Ohio. She is an active AARC member and member of the sleep section and a contributor to AARC publications and conferences. Jessica has no relationships to disclose, and I disclose that I am a paid employee of the AARC. Brand names of products may be mentioned only as examples of technology. Jessica, welcome to the program.
Thank you, Shauna, and welcome everybody. We're going to get started here and move forward with the webcast today. So similar to what Shauna mentioned about the brand names and kind of mentioning a lot of this, we are going to talk a lot about machines, different types of masks, and more specifically about each individual mask by brand, and there are pictures also in the webcast today. I did want to let everybody know the pictures do come from the manufacturer's website specifically, and so I just want everyone to know I'm not trying to steal photo cred from people, that these do come from them as well. So everyone is aware that that's where the information is provided, but without pictures we really can't talk too much about more specifics. So when we begin, we talk about the definition of apnea. And when we talk about the true apnea that we think of, everybody thinks about just the complete cessation of airflow. And most of that is 90% or greater for at least 10 seconds. Some of that can be even longer. And most of the time when people think of apnea, we just think of the standard obstructive apnea. These are the ones that are resulting from the upper airway obstruction, a physical impairment that can possibly be causing the patient to stop breathing during the night. But we also have to think about, too, the other types that we have and making sure that our patients and clinicians are aware of all the different types of apnea that could possibly be present when they are being diagnosed. Essential apnea, can also happen when there is the brain not able to send the signal to the respiratory muscles, and then we see the cessation of breathing as well. Mixed apneas come in combination of both the obstructive and the central apnea, and they generally start out as a central apnea and then end in an obstructive apnea. And then the complex apneas, we also see these also referred to as CPAP emergent centrals. These generally are found on the CPAP titration night. Most of the time the patient will present with obstructive sleep apnea on the diagnostic study, and then once we put them on some sort of positive airway pressure, generally starting with CPAP, and we continue to titrate the pressure, the higher pressure will then lead to centrals emerging. And so most of the time it is captured during that titration night, and if your technician is good, they'll know to kind of back down on the pressure and start down on a lower setting. And many times these patients won't understand what happened during that time, but many times it is the result of blowing off the CO2 that has been retained over time from the apnea. And to ensure that it actually is complex sleep apnea, we have to let the patient know and understand their history to understand that there is also not a clear cause for the central apneas. It has to not be a patient who's on chronic pain medications, generally doesn't have a history of a traumatic brain injury, doesn't have central components, from their, congestive heart failure or any other reason that they should have centrals emerging on that study. This is a nice picture that kind of breaks down the three usual types that we will see, the central, obstructive, and mixed, to kind of give you a nice visualization of what the airflow, what your diaphragmatic excursion should look like, and obviously what your oxygen saturation should look like. During the night, obviously, we're going to see that cessation of airflow with each type. But what we should obviously see with obstructive, we should see that the diaphragm is working, you're still trying to breathe, and then with the central apneas, there is no diaphragmatic excursion, there is no effort from the diaphragm and from the chest there. With the mixed, again, like I said, you will see the central start in the beginning, and then the apnea then ends with the obstructive apnea. And all of the apneas obviously show the DSAT that we will see. To characterize the severity of apnea, we need to understand how many times does the patient have these events throughout the night. And everybody stops a little bit during the night. Once it's more than 5 times an hour, it's considered significant, and we have to do something to help the patient. And so what we usually want to address with the patient is, how many events did they have when we saw them for the titration study, or for the diagnostic study, I'm sorry. Mild sleep apnea is defined as 5 to 15 times an hour. Moderate's 15 to 30 times an hour, and severe is anything greater than 30 events per hour. One of the things we see very common in our sleep clinic here at Ohio State is upper airway resistance syndrome. And this is one of the conditions that happens where the respiratory disturbance index is elevated, but your apnea-hypopnea index is within normal limits. Our sleep software actually does categorize both the AHI and RDI. And so when you see this is when most of your patients will come in complaining of snoring. They'll have the arousals during the night, and they will generally complain maybe of, some witnessed apneas as well, generally complaining of daytime sleepiness, not really feeling refreshed when they wake up. But when they go through the sleep study, they don't have the desaturations during the night that you would expect to see that would cause them to have an elevated apnea-hypopnea index. We tend to see this a lot with more of our healthier, younger patients. And so what ends up happening is that these patients, will complain, they're having symptoms, they need treated, and many of our insurance companies will not pay for treatment based off of RDI criteria alone. They want the elevated apnea-hypopnea index, obviously, because what happens is just an elevated RDI alone is not considered as detrimental to your health just because there's the lack of the desaturations. So the risk for stroke, heart attack, elevated high blood pressure, elevated blood sugars, those aren't really seen with the RDI being elevated as much as we see with the AHI. So most insurance companies don't see this as a strong risk factor down the road for health issues, and they don't really feel the need for treatment. So what we do try to see is if we can do something to help treat the upper airway disturbance if possible. And so many times weight loss is a good indication that we could try for these patients. If there is some sort of upper airway surgery that we can proceed with, we'll try that as well. But many times we can try CPAP if the insurance will let us. So what do we use CPAP for? So CPAP is the gold standard of treatment for obstructive sleep apnea. We can use it for complex sleep apnea, generally used in the first 3 months at a low pressure to see if the complex sleep apnea does resolve. In about 85% of patients with complex sleep apnea, the centrals do go away once you put them on CPAP, and so we do try them on CPAP first before pushing them forward through a titration study for possible ASV therapy. One, to save them from having to go through another titration study, but two, to save them from needing an expensive machine when maybe they don't. The other 15% obviously do not resolve and may need ASV therapy down the road. We will try it again, like I said, for upper airway resistance syndrome. And in this, we have found there's kind of like a 50-50 mix with patients in the resolution of their daytime symptoms. Sometimes we'll put patients on this for their upper airway resistance syndrome, and they'll come in and say they feel a world of difference, they're refreshed, they feel, their sleep is much more consolidated, and obviously the snoring has resolved. And then the other 50% will probably come in and say, I didn't notice any difference since I started the CPAP. I think I'll just go ahead and stop. So CPAP was invented back in 1981 by Dr. Colin Sullivan, and really, I always like this quote because, as an RT, you think about, equipment when you first started back in school. Every time you would sit there and as you kind of inherit pieces and parts when you go through the program, you get a lot of hand-me-downs because, you don't get nice new shiny stuff ever. And so thinking back about, what his first CPAP machine probably was like, you just think that, oh my goodness, the most barbaric pieces of equipment that these patients probably had on their face, but thinking about what it revolutionized for these patients in the form of treatment. So the treatment plan started off with a reversed vacuum cleaner motor that blew air into the afflicted person's nasal passages using a celastic tubing to keep the airway open. And then in 1990, the bubble mask was invented, and the home CPAP was changed forever. And what the bubble mask was, it was the first self-sealing mask, which allowed PAP therapy finally to be used in the home. And so now patients were a little bit more apt to being able to use CPAP without needing home health nurses, aides, therapists coming out. And now over 1 million patients use CPAP at home today. So a prime example of one of the old CPAP machines is here. I mean, when we think about some of the machines that our patients bring into clinic, or some of you who work DME and have worked for years, you can imagine what the machines were like or remember what they were like. As my patients start coming through now and we start replacing some of their older machines, they always like to bring what they call their archive devices to me because they know I really like to see some of their older machines. And many times, if they're not working anymore and such, we'll take them apart and look inside. And many times my patients are curious what the meats are inside of that machine. And so we'll kind of take it apart and look at it together and understand a little bit more about their CPAP, and it gets them engaged a little bit more in their care as well. And CPAP machines today, I mean, obviously this is the new, the AirSense by ResMed and the new DreamStation by Respironics. And obviously, you know, CPAP machines nowadays are smaller, they're more quiet, easily portable for patients. The technology that the patients have even today to be able to see what their night-to-night use is, what their residual AHI is, having, you know, auto-adjusting machines as well. The technology for humidification is amazing, you know, and the masks just keep getting better and better as well. And CPAP is just really revolutionized. You know, I have patients that come into my clinic some days and say, well, I tried CPAP, you know, 3 or 4 years ago and it really wasn't for me. And I said, well, you don't even know how things have changed in 3 to 4 years. You know, I think that maybe this time around it could be a lot different for you. The world of travel units has really made CPAP more flexible as well. Many times patients didn't take CPAPs with them because they didn't want to have to take the big bulky traveling case. They didn't want to have to take, you know, the CPAP and the humidifier and, you know, everything else that goes along with it. And so the patients, I always explain to them when we're sitting there talking about, do I take it when I travel? Well, do you want to sleep restfully while you're traveling? I mean, do you want to have energy to enjoy your vacation? Of course you do. And so, you know, I tell them, I encourage you to take it when you travel, but obviously if it's, you know, a matter of you taking something else instead of the CPAP, I can't force you, but I encourage you to do so. So many times now we have these smaller travel units. One in particular example here is the Transcend. And this machine initially was designed to be used for international flights. As you can see from the hooks on the side here, this machine actually was designed to be worn on the head. The mask and hose actually can connect and come down so the patients could wear them on the airplane itself. And so these patients will come in and say, I want the smallest little thing I can take with me. And humidification, the CPAP actually fits into the humidifier there. It comes with all kinds of accessories you can get to recharge the machine up. Solar panels if you're a camper. You know, we've had a lot of patients that just, you know, want to go away and have no way of getting electricity. And so this allows them to get some sort of battery access and recharge it. The other option too is the Z1 travel unit, and this one, you know, when patients see this, I mean, sometimes they look at me and say, that's a CPAP machine, and I'm like, weighs less than a pound. And so with these types of machines, there really are no excuses for patients to go without CPAP. However, the biggest problem with these travel units is that they do not make them in a bi-level and obviously any other type of advanced machine. So if your patient's on CPAP or auto-PAP, this works fantastic for them because they have an option. However, if your patient does need a bi-level or obviously a bi-level ST and ASV, they don't make them in these smaller units for them at this time. Auto-PAPs are an auto-titrating device, and one of the things that auto-PAPs have become much more advanced and popular with right now has been the kind of market revolution with the home portable sleep studies. We are now seeing auto-PAPs coming in as kind of first-line therapy after a home portable study, and so many times our patients, this is what they're getting after they've been diagnosed. You can use, obviously, an auto-PAP after an in-lab PSG. You can use it even after a titration if you're not comfortable with how the titration went. We use the auto-PAPs a lot too. I work a lot with the bariatric populations, and so pre-surgery, as long as our patients don't have any indication that they have hypoventilation syndrome, we can go ahead and use the auto-PAPs for them, because post-surgery, one of the big things is that after, you know, weight loss surgery, they're going to be losing weight pretty rapidly. Their pressure requirements are going to change with the weight loss, and so we want to make sure that instead of sitting there and you know, making them come in once a month, every few weeks for a pressure change, we can put their machine into the auto mode after surgery and allow the machine to kind of adjust for them based on what their needs are. And so we also use this a lot too for patients with positional apnea or those with more REM-dependent sleep apnea, because you'll find that if these patients you know, roll to their back, they're sleeping supine, and then all of a sudden they're back on their side, you know, many times they may not need that pressure to be quite so high. Or, you know, they come into the lab And in non-REM sleep, I mean, their AHI is maybe, 5 an hour. When they go into REM, their AHI is 75 an hour. You want to make sure you're getting a pressure that's appropriate for them that's going to take care of their apnea throughout the whole night. So a lot of times we'll try this for them to make sure that they're the most comfortable with the pressure as well as adequately treated. A bilevel S, we generally use this again for obstructive sleep apnea. We can use it for acute respiratory failure, a lot of times in the hospital inpatient, or with chronic respiratory failure. We see this used a lot too with COPD patients, with restrictive lung disease, and also used with obesity hypoventilation syndrome. So again, what we're trying to achieve with a bilevel S is to help ventilate the patient as well as oxygenate the patient. And what we ideally want to do is set your EPAP to make sure we're taking care of any obstructive apneas. And if we're using it more for the ventilation side, for respiratory failure, or the lung disease side, we want to just make sure it is enough to oxygenate the patient. The bilevel STs, criteria-wise, mostly used for central sleep apnea. However, we also use these, again, for COPD, neuromuscular disease, and for hypoventilation syndrome. So, again, we're trying to make sure that we're getting these patients adequately ventilated, giving them enough EPAP to keep the airway open and enough IPAP or pressure support to make sure that we are ventilating these patients adequately. And then the backup rate with the bilevel ST is just to make sure too that if they do have, obviously for the central sleep apnea component, to make sure we're giving the centrals taken care of. But for the neuromuscular disease and the hypoventilation syndrome, it just helps to make sure that their minute ventilation does stay consistent enough to ventilate them adequately. So the AVAPs and the IVAPs, these are volume assured pressure delivered ventilation devices. And what we use these for, ideally, are for patients with chronic hypoventilation syndromes. Again, COPD, neuromuscular disease, and obesity hypoventilation. And really the difference between these and, say, the BiPAP ST is that you're setting your pressures, but you're also setting a desired tidal volume that you want to achieve. And ideally, what you would like to do for these patients is set a tidal volume around 6 to 8 cc's per kilogram of their ideal body weight to ensure that you're getting an appropriate ventilation for them. And you can also check, blood gases. You can check overnight pulse oximetries to make sure that your patients are getting what they need. Most of the time, as patients do pretty well on these devices, they're usually pretty comfortable with these devices. You can titrate these in the lab as well to kind of see where you need, using end titles, getting gases in the morning, but most of the time it's going to be ABGs as you're progressing through with therapy. Adaptive servo ventilation, we generally use this for central sleep apnea, complex sleep apnea, and Cheyne-Stokes respirations. And I put that little asterisk there because we're going to talk a lot about the wonderful Cheyne-Stokes respirations and how things have changed in the last couple of months with that. So what is an ASV? Well, it's used to treat patients, like I just said, with central sleep apnea, complex sleep apnea, and Cheyne-Stokes respirations. A large population that uses the ASVs are patients with congestive heart failure. And how we set an ASV is we usually have the EPAP can be fixed or variable, generally to treat an underlying obstructive apnea. And then we'll set a pressure support min and max. And this actually will vary based on the patient's own breathing pattern. And I'm going to show you an example using the Philips Respironics ASV, or the adaptive servo. It will increase as their peak flow or minute ventilation decrease. And your rate can either be an auto rate, meaning that it reads what the patient's normal is set at and continues to maintain that, or you can set a backup rate to maintain. So this is the servo ventilation algorithm that Philips uses, and this is, again, just for an example. So what it does is over 4 minutes, it goes on a breath-by-breath basis to capture the peak flow, and it's monitoring it over that 4-minute window to see what the patient's normal peak flow would be. Once it starts sensing the decrease in the peak flow, it starts increasing the pressure support to get it back to the target peak flow that it is falling below. So you can see the example there of some periodic breathing or Cheyne-Stokes respirations, and you can see how the pressure support has changed down in the bottom where the auto SV has kicked in to give that patient the pressure support desired to get them back to normal breathing patterns. So what exactly is Cheyne-Stokes respirations? So it's a crescendo-decrescendo respiratory effort, an airflow during wakefulness or sleep without upper airway obstruction. We generally see this happen with central apneas. And mostly patients were using it to try and correct for their hypercapnia and to overcompensate due to increased circulatory time caused by heart failure, leading to delay in the response. So what generally happens is these patients will have a drop in their oxygenation. By the time their heart pumps back to their carotid receptors to say, hey, there's a drop in my oxygen level, the brain is kind of trying to catch up and, send, hey, we should slow down and stop breathing. Well, then the pattern starts, getting into this, well, now I've slowed down my breathing, and then it starts, changing things up, and the CO2 rises. And by the time everything kind of follows in this loop, the loop is delayed. And essentially the body just never catches up. And so you see this, basically the patient is hyperventilating and then hypoventilating throughout the night. And this can happen even during the day too. What kinds of patients may be at risk for Cheyne-Stokes? Mostly more of the male gender, patients who are of advanced age, those with atrial fibrillation, and those who are hypocapnic. So one of the big reasons that we're bringing this up was the most recent SERVE-HF study, and this came out in May by ResMed, and they released their special safety notice regarding their ASV devices. And they had this new study that came out that they were researching over a 5-year period, and they had seen an increase in mortality by 33% over the 5 years in their treatment group using ASV. And it was suggested that maybe ASV be reconsidered in these high-risk patients. And so who were the patients who were considered at risk? Well, they were the patients who had obviously central sleep apnea, and they were more predominantly central sleep apnea. And what it was, you had to have at least an AHI greater than 15, central index greater than 10. Patients obviously had to be on ASV therapy. That's why they were considered in the treatment group. And they also had to have symptomatic heart failure, and that's the New York Heart Association class 2 to 4. And then they also had to have a left ventricular ejection fraction less than or equal to 40 to 45%. So kind of pretty sick patients here to be considered. And so these patients who met all of the criteria, these patients were the ones who were having the higher mortality with the ASVs. So one of the plans that we implemented here in our clinic when this came out was we had to identify all the patients who were at risk, and so that took a lot of time. And then we had to start reviewing all the patient information that we had, and we had to contact patients about the safety notice. Well, many of the patients actually got contacted by their DME, and this was actually before we had the opportunity to contact them, which did not help us. And so what happened was they kind of got a little bit of panic induced, and we had to kind of calm things down a little bit, because many of these patients that we had that were on ASV therapy maybe didn't meet all the criteria, maybe they met none of the criteria, maybe all they had was they were on ASV therapy, maybe they had central sleep apnea. We have a lot of patients on, as you see, for various reasons. They may have centrals, they may have complex sleep apnea, they may have other reasons that they may have ASV. And so to really have all of the criteria met, that was really a very small group. But we reviewed their old sleep studies. We ordered new ones if we needed updated ones, because we wanted to maybe go back and review some of the centrals to see if maybe they needed rescored. And we ordered echocardiograms if one had not been documented within the last calendar year. We also would assess for signs and symptoms of CHF, shortness of breath, orthopnea, edema, anything like that that the patient may needed. If the patients met all the criteria, we documented a note, we offered the patient a visit to come in and discuss, and the options that we offered them was, 1, continue ASV therapy as is, no change, and many of them did. We could change their ASV therapy to CPAP. We can discontinue therapy and actually just treat them with oxygen insurance permitting, or we could go ahead and discontinue PAP therapy and no further treatment was needed. And so I would say that most of our patients continued ASV therapy and some decided to convert to CPAP. Most of them were not very concerned. You know, it's like any other risk that you have with certain medications and such. You just have to be aware and educated of what can happen, and just let your patients know that this is where the potential risks can be. But we also let them know the potential risks of possibly dying from their untreated sleep apnea is probably higher than the potential of them dying from what may or may not have come from this study. So why is ASV thought to be bad now? And the problem is that Cheyne-Stokes used to actually be thought to be kind of more of a thing that we had to treat. And the problem is now that it's considered maybe more of a compensatory mechanism for heart failure. And if we treat it, we've now taken away the patient's natural ability to compensate on their own. So they think that maybe if we leave it as is, the patient may not have as many problems. So that's the end of the machine portion. We are now going to move on to the mask portion. Now, when we talk a little bit about the masks, I have several examples, and when we kind of talk a little bit about the masks, I do want to let you know I do not discriminate against brands. I love all the masks. And so when we use a lot of the examples of masks, I kind of cluster them by ResMed, Philips Respironics, Fisher & Paykel, and then there are some other options out there too. But the three main manufacturers are what we use a lot in our clinics, so that's what I use a lot of examples of, just because there are a lot of examples of them. But please be aware that there are many, many more out there, and you can always find them out there on your own as well, and you may have some better ones that you like to use as well in your clinic. But those are just the ones that I'm going to be featuring in today's presentation. So when we talk about masks, several things when I'm educating students and fellows and talking to new employees, and we're talking about masks, I always say, know your patient and ask questions. And when they say, well, Jessica, what do you mean about that? And I say, well, you need to understand, one, who is your patient sleeping with? Are they sleeping alone? Are they sleeping with the dog? Are they sleeping with a bed partner? Are they sleeping with a bed partner all the time? And so why this is important is, one of the big complaints that we have a lot of time is from the exhalation port from the mask. And so sometimes you may need to find a mask that's going to work better for your patient that is a little less bothersome to a bed partner. You may also need to make sure that the mask is not scary. If you have a patient that sleeps with a small child in the bed, you may not want to go right to a full face mask. I mean, you may need to start small and then kind of work your way up until the child is accustomed to the CPAP mask. There's a lot of different things that you have to kind of work with your patient as well as what environment they're going to be taking the CPAP into, so that you are not overwhelming them, but you're also not making them kind of set up for failure right from the beginning. I also like to know too, what is your past examples of CPAP? Do you have family members who have tried CPAP? Have you ever tried CPAP before? Have you ever seen a CPAP before? What are your thoughts on a CPAP mask? Do they think they're coming in and putting a Darth Vader mask on, or do they actually know what a CPAP mask looks like? So I like to know what their expectations are before they come in. My next point is sometimes a big pet peeve of mine, and this is just because I feel that this happens more times than not. They'll ask the patient, are you a mouth breather? And many times they'll stick my patient on a full face mask right from the get-go. And I understand, that this is a huge concern, but I always say, who cares if you're a mouth breather? You're a mouth breather because you have obstructive sleep apnea. And you're going to try and get air into the biggest hole you have, which is your mouth. Eventually, your mouth is going to close when you start CPAP, a majority of the time. Now, I understand our patients who have severe congestion, deviated septums, and nasal issues that they have to breathe through their mouth exclusively, and I cannot fix that, and they will need full face masks. But when you have a patient that comes in who says, yes, I'm a mouth breather, and then you put them on a CPAP of 7 and all of a sudden the mouth closes and now they're like, I'm stuck with this full face mask, you may have wanted to maybe try smaller. So I usually try to educate, start small, and if you need a full face mask, add it later. Chin straps are wonderful. They can be your best friend. Patient history of past traumatic events can really guide your mask fitting very quickly. Knowing, I'm not saying you have to sit there and ask them, have you, been in an experience or anything like that, but, when you bring a mask out and the patient looks at you and starts giving you this kind of evil face and saying, oh my goodness, this reminds me of the time I was mugged, or, I don't think I can do this because I have severe claustrophobia from an event, having some of this information on hand. I understand sometimes when you're in the DME setting, you don't get that information from the chart, and hopefully your clinicians who are sending orders are at least providing you with some of this information so that it makes it easier for you. But when you're in the clinic setting, this should be something that props up in the patient's history so that you're aware of what the patient may have been through to make this a lot easier for you. You should then know that you need to start smaller with something like a nasal pillow or even just a nasal mask, not going to the full face mask right away. And be flexible and be patient. And I put a smiley face here because obviously sometimes we get very frustrated with patients and we sometimes don't want to keep trying, and we want to, sometimes go with the easiest fit or the most obvious fit, and sometimes it's not the answer for all of our patients. So the different types of masks that are available, we have nasal pillows, we have nasal masks, we have full face, we have hybrids, we have oral masks, we have total face masks, and we have the specialty category. So in the ResMed nasal pillow masks, we have the AirFit P10, we have the SwiftFX, and the SwiftFX with the Bella headgear. Now with ResMed masks, one of the nice things that they do tend to offer is the For Her version. And I say that with a little caveat too, because the For Her is not necessarily for women. For Her just means that they do make them in a smaller version, so these can be worn by men, and they're starting to make them so that they're not always pink. As you can see with the Bella headgear, they now make it with the gray, so that, if men did want the option of the Bella headgear, they didn't have to have the little pink straps. And so this is, a good option for your patients who maybe have the smaller nostrils, who have a smaller head, who maybe need that ability to have a little bit kind of a tighter headgear. And so I tend to go to this a lot of times when my patients do need something smaller. I give them the option of the For Her. Respironics does have the Nuance and Nuance Pro. The difference between the two, they both have the gel and the pillow. The difference is the Nuance Pro does have the gel and the headgear on the side there. And they do have also the OptiLife, which was a great nasal pillow mask that had kind of almost like a faux chin strap built in. We do keep this in our clinic, and it's on one of the mannequins in the room, and patients are always like, is that a new mask? I want that. And so a lot of times patients still inquire about that because they do see the chin strap as an option for them. The F&P version is the Polaro Q and Polaro, as well as the Opus 360. Now, when we're talking about nasal pillows, one of the big important things that I always like to talk about with patients is looking at their nose. And I know that we all, we look at noses and things like that, but one of the things that's really important is the type of nostril and your shape. And so there are generally classifications of nostril shapes, and type 2 is the most common. I would say that when I look at my nostrils, I'm more of a type 1. I have very, very narrow nostrils, and I explain this to my patients. And so one thing I didn't say is that I will throw this out there. I do not require CPAP. I do not have sleep apnea. However, I do not put a mask on any of my patients that I have not worn myself. I try to take them home, and when we get new masks and demo masks and stuff, I try them on because I feel that if I haven't had it on my face, it shouldn't go on my patient's face, and I should be able to tell them how to troubleshoot based on what my experience has been. So when I've tried pillows, my nostrils, because I'm more of a type 1, my nostrils actually collapse the pillows. And I spent the whole night, no matter what pressure I had it on, just put it on an auto, I spent the whole night trying to sit there and fidget with the mask, and it really did not work for me. I was up all night. And so when I have patients come in and they'll say, I just feel like all night I'm just touching the mask, I'm not doing it, I'll look at their nostrils and say, you have the same problem that many patients do, and the pillows are not going to work for you. You possibly need to go to just a nasal mask. And so that's something that when you're looking at your patient's nostril shape, people think, well, I have a deviated septum, maybe that's not going to work for me, or I have these polyps, maybe that's not going to work for me. But nobody really thinks sometimes to look at the nostril shape and size. They think, well, the pillow should inflate and everything should work. But just take a look sometimes at what your patient's nostrils look like, because if you start with the nasal mask first, you may be more successful with that. And again, with the deviated septum, I'm not saying that nasal pillows are excluded here, because I have plenty of patients with deviated septums that do very well. The only problem here sometimes is, depending on how deviated the septum is, you may not find that the pillows fit evenly. The pillows come sized, you know, both sides are the same size. So if you're a medium nostril on one side, you're got to be a medium on the other. And so unfortunately, if, you know, you're not an evenly shaped nose, the pillows sometimes don't work well for you. When we move on to the nasal masks, with the ResMed version, we have the Mirage FX, we have the Swift FX Nano, and the AirFit N10. I don't know how many of you had experience with the Swift FX Nano or used the Swift FX Nano. When this mask actually came out, we were really excited. We were like, oh, and how ResMed described it to us, it was like when the Swift FX and the Mirage FX had a baby and came together with this mask. And we had a lot of patients who really wanted it, and then most of our DME companies didn't carry it because they didn't make a separate cushion for people to get. And so unfortunately, it really kind of fell through in our area here, and I don't know if any of you guys used it out there, but we were really excited about that. I do have a few that get it. We have a CPAP retail store here in town that they're able to get that kind of stuff from. And so there's several options for you there with the nasal. One of the things that has really changed in the world of kind of nasal and full face masks is that a lot of the manufacturers are trying to take away the forehead piece and open up the eyes. And this allows patients a little bit more flexibility in the fact that you can wear your glasses when you go to bed, you can still watch TV, and this makes patients more susceptible to putting their CPAP on when they're getting ready for bed, and you know, it makes it more of a nighttime routine for them rather than, okay, I have to do everything I want to do and then put the CPAP on. Respironics has the Comfort Gel, the Wisp Nasal, and the Pico. And then they also have the new DreamWear Nasal. And the DreamWear Nasal, for those of you who've seen it, I know many of you probably went down to Congress, probably got to see it. And if you've had the opportunity in your clinic or wherever you work to get to see it, it looks like large bore oxygen tubing that inflates, and it goes just right underneath the nose. It's not pillows. It does not fit into the nostril. It just fits an underneath cushion. And so they were able to get that billed as a nasal mask. And then the hose connects at the top, and there is an exhalation port right at the nose as well as at the top. And so the big thing that I noticed with that, though, is that the exhalation port at the nose is kind of just an open port, whereas many of the other exhalation ports, if you're aware of them, have more of kind of like a filter or some sort of screening, so it's not like direct airflow. So that may be important for bed partners to be aware of. And as you lay on one side or the other, the air gets redirected through the other tubing side. The F&P nasal masks, we have the ESON, the Zest and Zest Q, and then the FlexiFit series. And I didn't put all the FlexiFit masks on there, but you can kind of gauge that they all kind of look similar there. So one of the things that we see a lot with nasal masks, this becomes a problem with patients who have what we call the nasal bump. And this also is an issue too with full face masks. We'll have patients complain of issues, and they're saying, oh, I'm getting a lot of breakdown right there on the bridge of the nose. And sometimes it could be a matter of they're pulling the mask too tight, they're not fitting things correctly, they don't have the right size mask. And so a nasal bump sometimes too, though, can create more of a problems with your mask. So you want to look again at the anatomy and decide if this is what's right for you. If they're using a nasal, you may be able to go to pillows. You may also want to try a different full face mask, and I'm going to show you a good option for that as well. The one thing I did want to mention about the N10 is that it does have magnets for the connection, and so what you do want to know is that you do have to keep the magnets 2 feet at least away from any pacemakers, and so if the patients do take it off at night, you just want to have them keep it away from their chest. So ResMed's full face masks, we have the Quattro FX, the Quattro, the AirFit F10, and then the Quattro Air. And again, you can see some of the masks again trying to take away the forehead piece to open up that the eye view. The Respironics full face versions, the Amara View, which is their newest full face mask, and then the Amara and the Amara Gel. And what I was talking about before with the nasal bump, the Amara View works really well for that because basically this rests just below the nose and then covers the mouth. And so the patients actually don't have anything on top of the nose or around the bridge of the nose, so this gives them a little bit more flexibility when it comes to some of the breakdown that they may get around the nose. And the simplest from Fisher and Paykel. So retrognathia is actually a condition that is where the jaw is receded. They have a smaller jaw. It is in more a posterior position. This actually does put you at a higher risk of having sleep apnea and does kind of put you at a disadvantage sometimes when you're looking for masks. If you're going for a nasal or nasal pillow, it's not really a big problem. However, if you're thinking that you may need a full face mask, sometimes this can be an issue. The gentleman on the left really isn't that big of a problem. I'm sorry, the guy on the right for you guys, but the guy on the left might be an issue. We had a patient one time that the Amara View worked really well for her because basically if you think about it, it's kind of standard you know, physics leverages here. If you're thinking about putting, you know, the mask at the nose and then at the chin base, you're trying to leverage that mask and get a good fit. You're going to end up getting some point that's going to have too much pressure. And so sometimes using a mask that maybe doesn't create as much pressure, and so using that Amara View that maybe goes right underneath the nose and then gives you a little bit more pressure at the chin might help for these patients. The hybrid mask that we usually recommend sometimes is the Liberty mask. This is one of the versions out there that has the nasal pillow for patients who like the pillow, but then the mouth portion for patients who still need coverage around the mouth, so if they are still a mouth breather despite the pillows. You do independently size the pillows, so each one can be a medium, one can be a small, and then the mouth is independently sized for whatever size you need your mouth as well. The Oracle by F&P is an oral-only mask, so if a patient has a significant nasal deformity, there's some sort of breakdown, you know that there's no way they're really going to breathe through their nose, you actually can try this mask for them. What it does recommend is that there are nasal plugs that they do wear for about 2 weeks or more to help them kind of retrain to breathe through their mouth, and then eventually they should be breathing through their mouth exclusively. However, we really don't have a whole lot of success with this mask. There have been a couple of cases where, there have been, like I said, significant issues where these patients, just cannot ever breathe through their nose, and this has worked for them. But when patients have actually asked for it, it really didn't work well. The Respironics Fit Life is a total face mask. We use this a lot more on the inpatient side, but once patients do get discharged, many times they do want this mask, and I've actually heard from many patients they're less claustrophobic with this mask than with full face masks. So in the specialty mask category, we have the Sleep Weaver from Circadians. They have 3 versions of it, kind of mimicking the nasal pillow, the nasal and full face. They have the Advanced, the Elon, and the Anu. These masks are cloth only. They do have some sort of rubber material that does give them some support, but they do leak very easily, and especially at higher pressures. But I've tried it before, and I was able to get it to seal. However, I was sitting upright and not trying to really sleep that well with it. But I have a couple patients who need this because they've had some sensitivity to the material from the mask. This is the PAP nasal pillow mask. This is made by the same company who makes the Thornton Adjustable Positioner, or TAP mandibular advancement device. And so as you can see, that it is part of a TAP device as well as part nasal pillows. And so what you do is you boil the mouthpiece for 5 minutes. You put it in, and it fits snugly on the top part of the teeth, and then the pillows just fit right into the nostril, and then the hose goes up and over the head. And so this allows patients to have no headgear on their face, gives them the ability to still use CPAP, but without any type of headgear at all. And so I've had a couple of patients order this. It's really difficult to fit them in clinic because, well, it's hard to get boiling water. But 2, there's screws that you have to adjust to really get everything just in place. So it's kind of difficult to really get this set for patients. So you kind of have to give them just really good directions when they're on their own. For patients who need support, chin straps are wonderful. There's lots of different brands and manufacturers out there. These are just 3 examples. The PAP cap is a total hat chin strap. I had a patient one time ask for it, and so sometimes just giving them the support that they need to keep their mouth closed will allow them to be able to continue using their smaller CPAP mask, nasal or nasal pillow, without going to a full face mask. Also help with mouth dryness if they are getting some dry mouth, and just help sometimes with that relaxation that they may be getting during the night, that the mouth may just kind of slightly drop open. The Remsey cloth liners are a great addition for patients who may be having some skin irritation, skin breakdown, leak. They're supposed to help minimize some of the leak as well. They do make these in full face nasal and nasal pillow version. They used to be able to be billed for patients as a cushion. However, most insurance companies do not cover them, so they are considered a luxury item and patients can pay for them out of pocket. They're made of cotton, so patients do like that soft material. I don't think they're very easily washed because they're very thin and can fall apart, but I've had patients kind of reuse them so they don't have to use a different one every night. But they really like the fact that they have a little bit of a liner. This works really good too for a lot of female patients who tend to not want to give up a lot of their nighttime cream routines to put the CPAP mask on, so this gives them a little bit of a less kind of that greasy material against the mask so things don't slide around. The ResMed Gecko Gel Pad is great if you do get some of that skin breakdown at the bridge of the nose. This just provides a little bit of support for patients so that they do have a little bit of gel right there at the bridge of the nose. I use this a lot for some of my older patients who have that very thin skin up there. And if they do start to get some breakdown, there is no adhesive on this device, which is really nice so it doesn't pull away. You just wash it, reuse it, and I usually will recommend to patients each time you change your cushion, go ahead and change your Gecko pad. Tubing insulators are wonderful, especially if patients don't have heated tubes. Here in Ohio, Medicaid doesn't pay for heated tubing, so our patients don't get climate-controlled tubing. So many times if they want to increase their humidity, because our temperature changes so much here, a lot of times our poor patients will get condensation in our tubing. So we'll recommend some sort of tubing insulator to help. This way they're able to get the moisture they need to prevent dryness and congestion without drowning from their CPAP. And then random CPAP pillows. Many times this can help the patient become more successful because they get some sort of option to help with their sleep at night. They'll complain that they can't get a good pillow, they can't find a way for them to sleep because their mask is getting dislodged, they're getting more leak because they're pushing up on it. So trying to find a nice pillow for them is a good option. That way they have a little bit more flexibility. These are just 2 options, and I always tell patients, try and see if you can find one in a store before so that you can kind of try it out. That way you don't have to try and return something online. Find one that has the firmness you need as well as the support and as well as the places that you may need for your mask. Nasal congestion is a big complaint we have. We use a lot of nasal steroids here. We'll recommend oral antihistamines if possible. I will suggest sometimes adjusting the humidification. Many times sinus rinses are very important. We always tell them use distilled water only with that. GERD can sometimes be flaring up and causing a lot of the drainage, the postnasal drip. Changing filters or adding filtration to the bedroom is a big one. I see a lot of patients, they'll come to my clinic and I look at the back of their machine, their filter's either gone or they haven't changed it in years or they didn't even know that they had filters on the back of the machine. And so education for your patients, making sure that they're aware of the filters, the frequency that they can get filters and making sure they're changing them is very important. And if they still have situations where they are still having congestion and possibly like dust allergies, add a filter to the room as well. And then if your patient's symptoms are still worse, you may have to refer to ENT for a possible septoplasty and/or turbinate reduction if you obviously see some structural abnormalities up there that may need repaired. And dryness is the last thing that we really have to address here. Many times, especially at this time of year as we're starting to get ready for winter, at least up here where it's super dry and cold, many of our patients are trying to find the right humidity setting. And so adjusting the humidification, maximizing what they can get out of the humidifier is important. Sometimes I'll just have them add humidification to the bedroom, just making sure they either, add just like a pot of water to the bedroom, or they can get, a room humidifier, something like that to just make sure there's more moisture. I recommend a lot of times different products. ACT makes dry mouth products, Biotene, things like that for dry mouth. For nose, we'll use the Air Gel, saline spray. NeilMed makes a dry noses spray as well as dry noses gel. Water-based lubricant, just straight up KY jelly works great. I tell them to avoid any oil-based lubricants though, no petroleum jellies, neosporins, anything like that. We'll assess for leak because that can be the biggest thing. If they're running out of water in the morning or if they have a significant leak, it's going to force more airflow to get that pressure. So that's a big issue that we have to take care of. And that can either be coming from their mouth if they have a nasal or nasal pillow mask. Obviously their mask can be leaking. There can be a tubing issue. So we want to take care of that. And then medication. Medication can sometimes be the problem. There's a lot of medications that cause dry mouth, but we also can use medication for a solution. There are some medications that can improve dry mouth. So if it does get too bad and you feel that that's what's keeping your patient from using the CPAP, you may want to suggest a medication for them or help them get a medication that can help with the dryness. So in summary, the right machine, the right mask can equal success for your patients. We want to understand all forms of apnea are pretty complex, but it's necessary for us to ensure the safety for all of our patients. You want to know your patient's facial features in and out before fitting their masks and work with them. If one doesn't work, encourage them that there is one out there that will. And that's one of the things I tell my patients. Just because one didn't work doesn't mean there's not. There's always another mask out there. And I always explain to them, if we can't find one, I will search the catalog and try to find one. And always be ready to troubleshoot. There can't be anything that you haven't tried that you can't try and give up on these patients. And so I always keep going through everything, and I tell them, I said, I haven't given up on you yet, and I'm not done with you yet. So unless you're ready to give up, and most of the time my patients are ready to give up before I'm ready to give up, I just keep trying everything in my bag of tricks before we get them out of here. And most likely they just don't come back before I've run out of options for them. But I usually keep trying until we've run out of anything for them. And that is the end. And so I'm going to leave this now to Shauna so that she can get the questions together.
Thank you, Jessica. That was really, really informative. I learned a lot of new stuff that I didn't realize. We have several questions, and I'm reading these in order of the posting, so we'll flip all the way back to the beginning of your presentation. And this question asks, can auto-PAPs have download capabilities to the doctor's office or the patient's computer for archiving and such?
They can, and most of the newer machines nowadays actually have either a built-in modem or the ability to add a modem. So one of the great things nowadays is we can actually get the real-time data same day. And so the physician's office can actually get it as well as the DME and as well as the patient. So there's a lot of great opportunities out there with most of the newer machines and even some of the older generations. So when I say the older generations, I'm meaning the ResMed, like the S9s and the System 1s, because even now the Respironics System 1s are kind of old now. But the new AirSense have the built-in modem from ResMed, and the new Dream Stations, the new white ones that just came out from Respironics, they have a modem that is not built-in. They decided to make theirs an add-on, but it just goes in, and so you can get the modem, and then the patients have a lot of ability to see data either from smartphone technology. They have apps that they can get on their, actually they can get data off the machine as well, but they also have things that they can get on the computer too.
Great, thank you. The next question is about the functionality of the devices as a whole. The person who posted states that, you know, that first breath after the apneic event is a big, deep gasp. Does that alter the information that's sent back to the machine and how it titrates and such?
So if we're talking about an auto PAP, it does. So for just an auto CPAP, it depends on the manufacturer. So with the ResMed machine, the way they titrate their device, they're a little bit quicker. I usually like to kind of describe the ResMed auto PAP is kind of like the hare, and the Respironics is like the tortoise when you're thinking of how they auto-adjust their pressures. And so ResMed goes very quickly. As soon as it senses the first apnea, it starts adjusting that pressure very rapidly up. It's more of a pretty steep incline, whereas the Respironics actually has to wait for, it senses, I think, 2 or 3 snores and apneas before it really starts increasing the pressure. And so depending on which machine you're using and which algorithm is built in, it can alter how quickly the machine adjusts and how fast the pressure is going to go up.
Thank you. And as someone who's not a primary sleep practitioner, that question didn't occur to me, so I was really glad that the viewer asked that one. The next question is about the different types of masks, and what about people who sleep on their stomach? Are there special masks that are detailed for sleeping on the stomach, or can most of the masks adapt?
Yes, so I was going to bring that up. Thank you for bringing that up, whoever did bring that up. So we have this happen a lot because many times patients sleep on their stomach prior to getting diagnosed as a compensatory mechanism for having sleep apnea. It is their way to fight gravity, and they're wanting to sleep in a prone position to fight that. Many times my patients who want to still sleep on their stomach after starting CPAP will usually go with a nasal pillow mask. However, with that being said, that's not always the only option. They will try alternatives, and I've had patients use full face masks and use nasal masks, but in the most part, it's going to be a nasal pillow mask just because it's the least invasive and the most comfortable for them to get adjusted to.
Fantastic. Good point. And the last question that I will ask, simply because we're running a bit on time, disposable micro CPAP device that was featured in the Sleep Review Journal in May of 2015. Do you know much about this device, and is this a feasible thing?
Yes, so this is the AirRing CPAP machine that they're referring to, and this was posted, mostly patients also saw it on Facebook, and when we saw this on Facebook, I thought, oh my goodness, my patients are going to be calling on Monday wanting it, and guess what they did? And basically what happened is in June, they went live on the Indiegogo to start getting funding for this machine, and they got enough money to start kind of getting the prototype developed. The idea, if you look at their timeline, if you go and Google it, and it's A-I-R-I-N-G, AirRing, and you can Google it and find their website. The timeline looks like if they get everything approved, July of 2017 will be when this machine will be kind of dispensed. And what's going to happen is this will be a disposable machine used like one-time deal, so you would use one little micro CPAP every night. Each little device would be preset to your pressure. And so the cost would be about $3 per device at this time, but if you used insurance, they're saying it's like 60 cents per device. And so it would have a tiny battery, tiny processor in it, and so the machine would be prescripted to be set at your pressure, and you would use it and then throw it away the next morning. And so I see this kind of coming in more so with the use for maybe more on travel, not really on a night-to-night basis, but it supposedly is going to be a real thing. You can give them money if you would like and be sign up for their web updates and such, but supposedly it is a real deal. But I don't know, you got to shove the pillows up pretty hard to actually get them to stay, because that's all the only option there is for it. But
great. Well, thank you again, Jessica, for joining us. This has been a wonderful session.
Oh, you're very welcome.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.